So if you've already figured out, go ahead and so that's going to be an 8. That's going to be a 4. So there really is a rule. That's a 0. That's an 8. It's going too fast. That's another 0.
Do it again.
Okay. Great.
All right. Do it again. Oh, I see it. All right.
Don't tell anybody.
All right.
Give me a 4. Give me an 8. And I didn't get it.
I don't get it at all.
And they say Bill Gates couldn't get it, which really drove him crazy. And he memorized the answer. He went to a website like this and just looked at the 5 die and memorized every combination for the correct answer, but never got it. Okay, those are the big ones. 12. So I'm George Bergus. I'm from the Department of Family Medicine in Iowa City. And I was going to tell you a little bit about me and ask you if you could share about yourself. The other thing that would be really useful for me is to know how much time you actually have today. Because I can cut different parts out. So I teach medical students, I teach residents. I'm have been very interested in kind of how physicians do what they do. And this talk comes out of that interest. And hopefully I'll give you some tools to help you help others. And in terms of how much time I have, I've got probably until 3 o'clock. But I know most of you don't.
About 1:15.
That's good to know. Okay. So maybe we could start at the end. And you could just introduce yourself and let me know what you do.
Dr. William Bailey. Number for this year.
Eloise Corbin, I'm a second-year resident.
I'm the first year, and I'm actually working.
I'm Courtney Knapps, I'm one of the pharmacists.
Care monitor, also a pharmacy resident.
Excellent.
Andrew G. I'm a second-year resident.
Okay.
Gary Heath, I'm a physician's assistant.
Reza Mohibi, second year.
Gary McGowan, faculty.
Yeah.
I'm Margot. I'm hospice education.
Great.
I'm sorry, I've been through it.
So we'll just do this one more time, and we'll come back. So that's an 8. So, great. So for me, I look at medicine as being problem solving. That people come to us with problems, and our job is to figure it out. And who can tell me what that picture is?
Picture of a dog.
Oh, that's good. It's a Dalmatian. And once you know it's a Dalmatian, you see a Dalmatian. A lot of people don't see a Dalmatian. Head, body, feet. And often my medical diagnosis, once you get the diagnosis, it's obvious. But it's never obvious to me during the process. And for me, as physicians, we do a lot of stuff. We fill out a lot of paperwork, billing, prior authorizations, you name it. But what's unique to us, I think, is really medical diagnosis. Problem solving is you start with a certain condition and kind of get to a final condition. It could be a Rubik's Cube or tic-tac-toe. And problem solving is your intervention. And do anything until you know where that patient is starting from. And what's really interesting is that, well, Olga Costapola, who's a cognitive psychologist in the UK, did some nice studies with primary care physicians and, using different cases that, if they got the diagnosis right, they almost always got the treatment right. If they got the diagnosis wrong, 78, so 3/4 of the time they prescribe the wrong treatment. So, this is not, all that surprising is that it's hard to give somebody the right treatment unless you get the diagnosis right. Once you have the diagnosis, you can look up the treatment in a book and up to date. So, if diagnosis is so important, how were you actually taught to do this?
Taking a good history.
Taking a good history. Okay. How about other people? Other thoughts?
A lot of it was hands-on, just repetitive, doing it over and over.
Mm-hmm. And then finally, you kind of saw.
Right.
Okay. Collect data from the patient. But how do you move from data to diagnosis? Different. Okay. So what did you actually find helpful when you were learning to do this? Think back to your third year of medical school, your fourth year, and you were expected to learn how to start doing this diagnosis thing. So what did anybody give you a tip that was particularly helpful?
One thing I learned was when you hear hooves, don't think of zebras.
Okay.
So think of things that are common in that area.
So a general rule is common things are common.
Right.
You got it. I got that same lesson as a third-year student. Or what mistakes do you often observe students making as they're trying to learn how to do medical diagnosis?
Bad physical exam.
Okay.
Just poor. Just overall, they don't want to hurt the patient. They don't want to touch them too much, rather than getting their hands into it, getting into what's wrong.
Okay. So bad technique.
Yeah. So then reevaluating the technique by showing them how to do it better.
Okay. So other mistakes people have observed.
Relying too much on labs and on orders that they can do,
Okay.
rather than evaluating the patient.
Okay. So rather than paying attention to the history and physical.
But I think that's a new breed of doctors that we're creating, is by, rather than relying on the patient, we're relying on labs. We're treating the lab rather than treating the patient.
Well, I heard that same thing when I was a third-year student. Now, young doctors now.
You know, a third-year medical student can probably do my job pretty easily by just ordering labs and then figuring out what's wrong, you know, and then going in an objective way rather than looking at the patient and saying what's wrong.
So when I was a medical student, I was trying to figure this out, and we were taught the do everything method, although there are other models as well that we're going to talk about. And we were taught that you got a good history. You just collect data. You don't try to analyze any of this information. You don't try to make sense of it. You just collect information. In fact, we were taught that if you try to think of the differential early, you were making a bad mistake. That you should just go in there with an open mind, collect all those symptoms, take your good history, do your good physical. And we were actually given a big handout, about 12 pages of all the information we were supposed to collect. And I don't know if, I suspect some of you got a similar handout. And if you're like me, you memorized all the things that you wanted to collect. And somehow, after we got the API, the past medical history, family history, social history, review of systems, the physical exam, light was supposed to shine on the diagnosis, and clouds opened, and it just never seemed to work that way, which was really frustrating. But if this is a model which we ought to be teaching our students, then we ought to tell them that they ought to be compulsive. They ought to collect everything. And everything should be collected by one individual, of course, because you're going to be really compulsive about data collection. The only problem is that numerous studies find that expert physicians actually don't collect more information than novices. They're not better because they collect more information. They're better because they collect the right information. Yeah, they might ask a question that the novice didn't ask, and it will lead to the diagnosis, or the novice might have asked after they have so much other information, they can't kind of put their finger on what's really important. So, unfortunately, it's not the amount of information that reflects expertise as a type. So, after those studies, people started getting interested in, well, there must be other things that expert physicians do. And in the 1970s, a cognitive psychologist at Michigan State did a pretty creative thing. He actually did simulation. He got standardized patients, and he trained them to do certain cases. He recruited docs that were considered expert by their peers, experts in medical diagnosis. And he put them into his laboratory with the simulated patients and watched what happened. And what he found is that physicians rarely ever did do everything. And what's kind of curious to me is that when he played back the interaction movies with the physicians and asked them what they were doing, almost always the physicians, they voiced embarrassment that they were, quote, cutting corners. They weren't doing what they were taught in medical school. They weren't collecting all the information. And they said, well, you know, they're really busy, that although they were taught to collect everything, they learned that they'd have to cut corners. So I want you to think for a minute. It's 1:30. You're standing in your clinic. You're getting ready to enter an exam room to see your next patient. You're looking at a nursing note, 70-year-old woman, shortness of breath that started yesterday and has chest tightness. What could be going on? Okay. MI. COPD. TB. Pneumonia.
Anxiety.
You bet.
Trauma.
Trauma. Pleurisy. Pleurisy. Yeah. Those are all pretty good. And what Elstein observed over and over again is just like you did. People do the differential very early. In fact, often it's after they picked up the chart. And typically these expert physicians had 3 to 5 different hypotheses. Each hypothesis was highly predictive of the question the doc was going to ask. And the whole diagnostic process was basically the process for sorting out this differential. So this might seem like common sense, but this was like a radically different insight than do everything, because docs didn't collect out all the information. They were highly specific. And no, they didn't do the differential at the end of their data collection where we always put it in our note. They actually do it very early. And the model was chief complaint, the differential, other data, sorting out the differential again, and diagnosis. So Elstein thought he got it. All we have to do is tell students to generate their differentials early. And then, being a good scientist, he put medical students in the same situation. Whoa, novices also would generate a differential when looking at the chart. It just seems to happen automatically. Now, of course, medical students often have bizarre things on their list, right? Well, experienced physicians have high-quality hypotheses, and experienced physicians are much better than medical students were about letting these hypotheses guide their data collection. They knew what data they were looking for, and often medical students hadn't figured that out. And the last thing that he found, and other people have documented over and over again, is that correct disease is not in your differential early during a clinical encounter. Within the first minute or two, we are very unlikely to come up with the right diagnosis. So spending some time on this differential is going to be important. Now, for many of us, it's easy to shout these things out. You know, somebody was showing us the breath, some chest tightness, it's simple. For a student, it actually takes a lot of work. Something that often they'll bypass. So you all came up with a great differential of shortness of breath. How did you learn that? How are you able to do that?
Well, from seeing different patients with shortness of breath from the past, just knowing their diet after their treatment and that, what they've been were treated for.
Okay. So through your clinical experience,
Right.
were there any courses you took that helped you? Because you obviously have no trouble coming up with a great differential.
We'll say yes. Anatomy and phys, I guess. Anatomy and physiology.
Okay.
You know,
Physiology, maybe.
Pathophysiology.
Pathophysiology, there you go. Very nice.
So I'd like you to start off with this green sheet. So yeah, actually your differential looks a lot like mine. You know, we're all practicing physicians, it's not surprising. And I want you to work with the person next to you and just jot down one or two things that you expect to find on your history and on your physical exam. What are you looking for? If that diagnosis is
I can do this
correct.
one. Yeah.